So now let's talk about the gastric reconstructions. Whenever we do any gastric surgery, a reconstruction has to be done, right? Either it has to be anastomosed with the duodenum or it has to be anastomosed with the jejunum. So there are two main types of reconstructions, Billroth 1 and Billroth 2. First, let's talk about Billroth 1 reconstruction. Now, Billroth 1 reconstruction, this is the stomach. The green one is the duodenum and purple one is the jejunum. Okay. Now I'm doing a distal gastrectomy. I've supposing removed this much of the stomach. Okay. I've removed this much of the stomach has been removed. I've done a distal gastrectomy. So once I've done this, what am I left with? I'm left with the cut end of the stomach. This is the cut end of the stomach which is there. And this is the cut end of the duodenum which is there. And this is the jejunum. Now we've discussed previously also, if the two ends are close to each other, I can anastomose them without any tension. And when I anastomose them without any tension, the chances of leak will be less. The chances of anastomotic leak would be less. So now because I've just removed a small portion of the stomach and the two ends are close to each other, I can easily carry out anastomosis. And I carry out an end-to-end gastroduodenal anastomosis, and that becomes Billroth 1 reconstruction. So end-to-end gastroduodenal anastomosis, and that becomes Billroth 1 reconstruction. Okay, we'll talk about the complications of all these reconstructions right at the end. This is Billroth 1 when the two ends are close to each other and I can anastomose them. That is Billroth 1 reconstruction. So you can see here, this is end-to-end gastroduodenal anastomosis. This is the stomach and this is the duodenum. We've done an end-to-end anastomosis there. Billroth 2 reconstruction. So now this is my stomach. This is the stomach which is there. Again, the same color scheme I'm using so that you understand better. This is the duodenum and this is the jejunum. This is the jejunum. Now I've done some bit more of resection. Okay, so I've done a subtotal gastrectomy. So I've done a subtotal gastrectomy. This much I have removed. So large chunk of stomach I have removed. So when I've removed this large chunk of stomach, what am I left with now? I'm left with the cut portion of the stomach. This is the cut portion of the stomach which is there. And this is the duodenum which is there. And this is the jejunum which is there. This is the jejunum which is there. Now you can see that the two ends, that means the stomach and the duodenum, are far apart now because I've resected a large chunk of the stomach. The stomach and the duodenum are far apart. Now we know that the duodenum is not mobile, so I can't mobilize the duodenum and anastomose it with the stomach. That cannot happen. And now that the two ends are far apart, we've discussed that if two papers are far apart and if you were to tie them with a thread, what will happen? The thread is going to tear through the paper. Correct. The thread is going to tear through the paper because of increased tension. So similarly, because the two ends are far apart, I cannot anastomose them end to end. So what do I do here? I will close the duodenum. We close the duodenal stump. This is the duodenal stump which has been closed. Okay. And what am I going to do? I'm going to lift up the jejunum from here. So I'm going to lift up the jejunum and I will anastomose the jejunum with the stomach. Okay. I lift up the jejunum and I anastomose the jejunum with the stomach. So I carry out an end-to-side gastrojejunal anastomosis. I carry out an end-to-side gastrojejunal anastomosis. That means the end of the stomach and the side of the jejunum. Why? Because you know the stomach opening is this big. It's quite big. Jejunum has very narrow lumen, so I can't do end to end. So that is why I make an equivalent opening on the side of the jejunum. Okay, that is why end to side I'm doing. So end to side gastrojejunal anastomosis I carry out. This one is known as Pollia reconstruction. Okay, this is Pollia reconstruction or Billroth 2 reconstruction. So I've demonstrated to you how Pollia reconstruction is carried out. We just lift up the jejunum and carry out a single end-to-side gastrojejunal anastomosis. So you can see here, this is my duodenal stump which has been closed. This is the duodenal stump which has been closed. And I have done an end-to-side gastrojejunal anastomosis. This is the stomach, this is the jejunum. So this is Billroth 2 or Polya reconstruction. Now another very common one. Remember I showed you that Y orientation and I told you I'll explain it to you in some times. The next type of reconstruction is Roux-en-Y gastrojejunostomy. So again the same color scheme we are going to use. This is the stomach. This is the stomach. This is the duodenum. This is the jejunum. This is the jejunum. Again, I've done a subtotal gastrectomy. Large portion of the stomach has been resected. This much stomach I've resected. So what am I left with? I'm left with the cut portion of the stomach. This is the cut portion of the stomach which I'm left with. This is the end of the duodenum which is far apart. And this is the jejunum which is attached to the duodenum. Okay. So now again the two ends are far apart. We know if the two ends are far apart, we can't anastomose them. So we are going to close the duodenum. This is my duodenal stump. This is the duodenal stump which is there. Okay. Now, how is Roux-en-Y different from Polya, which I've just told you? So here, what am I going to do? Here, 50 centimeters from the DJ flexure. Okay, this is the DJ flexure, duodenojejunal flexure. The duodenojejunal flexure, 50 centimeters from the duodenojejunal flexure, I'm going to cut the jejunum. I'm going to cut the jejunum 50 centimeters from the DJ flexure. Once I do this, now I have two portions of the jejunum. One portion of the jejunum is this yellow one, which is continuous with the ileum and with the rest of the bowel. Okay, this is the jejunum, which is continuous with the ileum and the rest of the bowel. Okay, and the other 50 centimeters is attached to the duodenum. That I'm coloring as green. This is attached to the duodenum. This is the 50 centimeters of jejunum attached to the duodenum. Okay, so now what are we going to do? I'm going to lift up this yellow jejunum which is continuous with the rest of the bowel, and I will carry out an end to side gastrojejunal anastomosis. Okay, so this distal jejunum which is continuous with the rest of the bowel, I'm going to lift it up and I'm going to carry out an end to side gastrojejunal anastomosis like we did previously. So this is the stomach, this is the jejunum. I've done an end to side gastrojejunal anastomosis, and this jejunum is continuous with the rest of the bowel. But now you need to understand that if the food does not mix with the bile and the pancreatic juices, how will the food get digested? So that is why this duodenum which was there, which I had closed, with the 50 centimeters of jejunum, I have to join it back into the jejunum. Otherwise, bile and pancreatic juices will not mix with the food. So I have to join this back with the jejunum. So here I've done two anastomoses. I've done an end to side gastrojejunal anastomosis, and I've done an end to side jejunojejunal anastomosis. Right, so two anastomoses have been done here as opposed to a single anastomosis in Billroth 2 or Polya reconstruction. Okay, and this is my yellow limb. This is the yellow jejunal limb which was continuous with the rest of the bowel which I had lifted up, and this is the green limb which was attached to the duodenum. And had the 50 centimeters of jejunum which I've joined back. Okay, so this yellow limb which I've brought up and anastomosed with the stomach, this yellow limb is known as the Roux limb. Very important term. I'm going to use this a lot of times. This is the Roux limb. Whereas this limb which is carrying the bile and the pancreatic juices is known as the biliopancreatic limb. This is known as the biliopancreatic limb. Okay, so these are the two limbs in Roux-en-Y gastrojejunostomy, and when we carry out the anastomosis, the appearance is like a Y. Right, it looks like a Y. That is why we are calling it a Roux-en-Y gastrojejunostomy. Okay, so like I showed you when we were doing the gastric procedures, like I told you, subtotal gastrectomy, then you will land up with this Roux-en-Y kind of a picture where this is the Roux limb and this is the biliopancreatic limb. And this gives you the Roux-en-Y kind of orientation. Another image which is depicting the same. This is the stomach. This is the jejunum. And this is my rule limb. This is the duodenum. And this is the biliopancreatic limb, which I've joined back. This is the second jejunal anastomosis which is there. This is the GJ, gastrojejunal anastomosis. And this is your Roux-en-Y gastrojejunectomy, which I've just explained to you. Okay. Now you need to understand that the jejunum, if you remember your anatomy, the jejunum is in the infracolic compartment, right? Infracolic means below the colon, and stomach is above the colon, above the transverse colon. So stomach is in the supracolic compartment, whereas jejunum is in the infracolic compartment. So I have to get the jejunum from the infracolic compartment into the supracolic compartment to anastomose with the stomach. Now I can do that in two ways. I can do that by two methods. One method is known as anticolic, and the other one is known as retrocolic. Anticolic means that when the jejunum is anastomosed after bringing it up in front of the colon, okay, that is anticolic. Retrocolic means jejunum is anastomosed, but the jejunum is delivered behind the colon. And how do we deliver it behind the colon? Through the transverse mesocolon, through the mesentery, through the transverse mesocolon, through the transverse colon mesentery, we deliver the jejunum up through the transverse mesocolon. Okay. So let me just demonstrate to you how this is done, and let me show you a short clip of anticolic versus retrocolic, and then I also want to highlight one more complication which can occur in each one of them. Okay, so let me just show you the demonstration and the video. So we've discussed that the stomach is in the supracolic compartment and the jejunum is in the infracolic compartment. Okay, so this is the transverse colon. Above this is the supracolic compartment where the stomach is, and below this is the infracolic compartment where the jejunum is. Now there are two ways to bring the jejunum up. One I told you is called anticolic. Anticolic means that if I just lift up the jejunum and I get the jejunum on top in front of the colon, right? So in front of the colon, by that I mean you can see here that this is the colon and the jejunum has been brought in front of it, okay? Now when I bring up this jejunum up here, this is the Roux limb which is coming up, right? This is the Roux limb which is coming up. Now there is space behind this Roux limb, and if another bowel, this my hand, if another piece of bowel herniates behind the Roux limb, if it goes behind the Roux limb, then we call it a Peterson's hernia. So this is one of the internal hernias when this bowel goes behind the Roux limb, okay? And this is anticolic. Now retrocolic is that this is the colon, and there is a transverse mesocolon. There is a mesentery of the transverse colon, okay? So this is the mesentery of the transverse colon, and if I make a window here, I've made a window here, and through this window the bowel is going to come up, right? Through this window the bowel is going to come up now. So this is retrocolic. That means now the jejunum is coming up behind the colon through the mesenteric window. Now this mesenteric window which is there, if one more loop of bowel herniates through this window, then we will call it the Stemmer's hernia, right? So this I just wanted to demonstrate. After this demonstration, when you watch the operative video, things would be much more clearer to you. So you can see in this is the window which has been created where the surgeon is pointing now. So he's holding the transverse colon, and there's a window which has been created in the transverse mesocolon. So this is retrocolic, where the jejunum is going behind the colon. You can see him showing the colon. This one is anticolic, where you can see the surgeon's hand is holding the colon and the anastomosis is on top of that. The anastomosis is on top. That is anticolic. Now, like I showed you in the demonstration and the video, in anticolic, we are getting the jejunum in front of the colon. In front of the colon. So the roux limb, if behind the roux limb, a loop of bowel herniates, that is known as which hernia? I've told you that is known as Peterson's hernia. That is an internal hernia known as Peterson's hernia. This has been asked in many exams. You should know about it. Whereas if a loop of bowel herniates if there is a herniation through transverse mesocolon window, through the window which I had created in the transverse mesocolon, if there's a herniation through transverse mesocolon window, then this hernia is known as Stemmer's hernia. This has been asked more frequently than Peterson's hernia. So these are two internal hernias you should know about. Stemmer's and Peterson's, both are associated when we carry out the Roux-en-Y gastrojejunostomy. I've told you how do they manifest, and I've told you about anticolic and retrocolic anastomosis. Okay, so this was your Roux-en-Y gastrojejunostomy and the anticolic and the retrocolic anastomosis which are done. The next thing which we need to talk about is vagotomy, right? We discussed that vagotomy is acid-reducing surgery. And where all is this vagotomy useful? Where is it useful? So it is useful for all duodenal ulcers. It is useful for all duodenal ulcers. And it is useful for type 2 and type 3 gastric ulcers. It is useful for type 2 and type 3 gastric ulcers. Now, before I tell you about vagotomy, a bit of anticlimax, I want to tell you that this surgery is no longer done, right? And the reason why we don't do this surgery is because proton pump inhibitors are as effective as vagotomy. Proton pump inhibitors are as effective as vagotomy. And this is a classical example where a drug has replaced the surgery, right? Because again, when we joined as postgraduates 5-10 years before that, vagotomy was the main surgery. A lot of vagotomies were carried out. Our seniors used to tell us, our professors used to tell us that they used to do a lot of vagotomies, even in the emergency. But since the advent of proton pump inhibitors, this surgery has been completely replaced because these drugs are wonder drugs. They can produce the same result as the surgery without any complications, without the complications of surgery. Okay. Anyways, there are a lot of questions in the entrance exams which are asked from vagotomy, so we should know about it. Now, before we talk about vagotomy, we should know about the branches of the vagus. So the branches of the vagus has two trunks. You have the anterior trunk and you have the posterior trunk. So this is the anterior trunk, the orange one, and the red one is the posterior trunk. First, I'm going to tell you about the branches of the anterior trunk, right? The first branch of the anterior trunk is a motor branch to the gallbladder. Very important. This is a motor branch to the gallbladder. And what this motor branch to the gallbladder does is it stimulates gallbladder contractility. So it pushes out bile from the gallbladder. Now, just in case this branch is injured or cut, then there'll be gallbladder stasis. And that can predispose to gallstones, which is why one of the complications of vagotomy is gallstone formation. And it's because of this branch, which is the motor branch to the gallbladder. Now, another branch after the gallbladder branch, another branch goes to the pylorus. You can see this branch which is going to the pylorus. And this pyloric branch is also a motor branch. This stimulates pyloric contraction. And there is the stomach, the food exits the stomach through this pyloric branch. Now, if we cut the pyloric branch, there'll be gastric stasis. right? Food will accumulate inside the stomach. So which is why if we cut this branch, we have to carry out a drainage procedure, right? So this can lead to impaired gastric emptying or stasis, and that is why we have to carry out a drainage procedure if we are cutting this branch, so that food does not stagnate. And the drainage procedure which is done, there are two drainage procedures. One is gastrojejunostomy, which I've spoken about in great length. One is gastrojejunostomy, and the other one is known as Heintke-Mikulicz, pyloroplasty. Heintke-Mikulicz pyloroplasty. So what is Heintke-Mikulicz pyloroplasty? Heintke-Mikulicz pyloroplasty is when we make a longitudinal incision. You can see here I'm making a longitudinal incision, but it is sutured transversely. So we are making a longitudinal incision. We make a longitudinal incision, but we suture it transversely. So you can see here, I make a longitudinal incision, but I suture it transversely. And when I do that, the lumen size or the luminal length increases, and there will not be any stasis. So basically, by doing this Heintke-Mikulicz pyloroplasty, I'm rendering the pylorus incompetent. Okay, so there won't be any pyloric sphincter there, and food will easily travel down. So these are the drainage procedures which can be done if we are cutting that motor branch. So once the anterior trunk has given off this branch to the pylorus, then it continues down as the anterior nerve of Latarsgit. And it branches out into the crow's foot. This is the crow's foot. These branches look like the crow's foot, and they supply the antrum, which is the acid producing area of the stomach. You've read that antrum is the acid producing area, and vagal stimulation is one of the major stimuli for acid production. Okay. The posterior trunk, which is this red one, gives off very early in its course a branch to the celiac axis. Then it gives out a branch which again supplies the antrum, the distal half of the antrum, close to the pylorus. This is known as the criminal nerve of Grassi. Very important for the exam. This is the criminal nerve of Grassi. And usually when we are carrying out vagotomy, this branch is left behind, or this branch can be missed. And if this branch is missed, this is the one which is responsible for ulcer recurrence, because it will keep on stimulating the stomach and producing acid. So this criminal nerve of Grassi is the one which is responsible for maximum ulcer recurrence post vagotomy. Now, once this criminal nerve of Grassi has been given off, the posterior trunk continues down as the posterior nerve of Latarsgit, this light blue one, and this also branches out into the crow's foot, which supplies the antrum. So these are the various branches of the vagus, and I've told you the clinical importance of some of these branches. Now the types of vagotomy which are done. So the types of vagotomy which were done were, one is truncal vagotomy plus antrectomy. This is the most aggressive one, where we are cutting the trunks of the vagus and we are cutting off the antrum, which is the acid producing area. On the other end of the spectrum, you have highly selective vagotomy. Highly selective vagotomy is when we just cut the branches of the crow's foot. That is highly selective vagotomy. And the middle path, a surgery which my seniors used to perform quite frequently, that is truncal vagotomy plus gastrojejunostomy, TVGJ. Truncal vagotomy plus gastrojejunostomy, that is the middle path. So let me just show you the image, and then I'll come back and tell you what actually happens in each of these surgeries. So truncal vagotomy means that we are cutting the trunk. If I cut here, this is truncal vagotomy. I'm cutting the trunk of the vagus. Highly selective vagotomy means, you see these are the crow's foot branches. So these crow's foot branches are cut. And if I cut the crow's foot branches, This is known as highly selective vagotomy. This is known as highly selective vagotomy. And distal 6 to 8 centimeters of the esophagus is skeletonized. Okay. But one thing which you need to remember, that we don't cut the branches to the pylorus. And why don't we cut the branches to the pylorus? Because that would lead to gastric stasis, correct? So that is why denervation is stopped 7 centimeters proximal to the pylorus, thus sparing the pylorus and the distal part of the antrum, okay? So that is why we don't denervate the pylorus, otherwise there will be gastric stasis. And because this 7 centimeters is not denervated, sometimes which nerve gets missed out? Correct. The criminal nerve of Grassi gets missed out, and that can give rise to ulcer recurrence. After highly selective vagotomy. Okay. So, truncal vagotomy plus antrectomy, if we look at acid reduction, if we look at ulcer recurrence, and if we look at vagotomy complications. So these are the three headers under which we need to talk about these surgeries. So acid reduction will of course be maximum if we do a truncal vagotomy plus antrectomy. So there'll be maximum acid reduction. And if there's maximum acid reduction, it is common sense that there'll be least ulcer recurrence. But when we are doing such an extensive procedure, there'll be maximum vagotomy related complications as well. Some of them I've already highlighted to you, like increased risk of gallstone formation. There will be gastric stasis, for which we need to carry out a drainage procedure. On the other end of the spectrum is in highly selective vagotomy, the acid reduction is less than truncal vagotomy plus antrectomy. It is less than truncal vagotomy plus antrectomy. And because sometimes the criminal nerve of Grassi can get skipped, that is why this has maximum ulcer recurrence rate. The ulcer recurrence rate here is less than 2%, whereas here it can be around 3 to 10%. There can be ulcer recurrence rate after highly selective vagotomy. The vagotomy complications will be least vagotomy complications, because we are just denervating we are just cutting off the crow's foot branches. Okay, so these are the questions which have been asked in the exam. Where do we get maximum acid reduction? Where do we get maximum ulcer recurrence? That I've already told you. TVGJ is the middle path where everything is in middle, which is why this was the most commonly performed surgery. Now, where exactly do we do highly selective vagotomy? So, highly selective vagotomy around 7-8 years back, this was asked that this was done for chronic ulcers. Now, of course, this has been replaced by proton pump inhibitors. Whereas truncal vagotomy plus antrectomy was done for recurrent ulcers. So, if you're solving very old questions, you can come across these two questions. For recurrent ulcers, it is truncal vagotomy plus antrectomy. Whereas for chronic ulcers, it is highly selective vagotomy. So I've told you about gastric reconstructions and I've told you about vagotomies. Now the last part of this module deals with the complications of these surgeries which we've just discussed. And these complications are frequently asked in the exam. I mean, almost every exam, there is one question from these complications. So what are the various complications which can be seen? So we can have anastomotic leak whichever surgery we are doing. Of course, there is a risk of anastomotic leak which can occur. There can be hemorrhage which can be seen, which can occur. There can be duodenal stump blowout. Duodenal stump blowout can be there. Now, in which two surgeries were duodenal stumps being formed? Right? Was it being formed in Billroth 1? No. This was Billroth 1. There was no duodenal stump. Billroth 2, correct. This is our duodenal stump in Billroth 2. In Roux-en-Y, correct. This is our duodenal stump in Roux-en-Y. So, duodenal stump blowout can occur on post-operative day 4. This has been asked. Don't confuse it with day 6. Day 6 is abdominal wound dehiscence, where the rectus sheath opens up. That is different. So rectus sheath opens up, that is burst abdomen on day 6. Duodenal stump blowout is usually on day 4. And the patient can come with abdominal pain and features of peritonitis. Okay. So that is duodenal stump blowout, which is another complication which can be seen. Other complications are bilious vomiting, because we've now anastomosed the duodenum with the stomach and the pylorus is not there. So bile can reflux up. Even through the jejunum, bile can come into the stomach and there can be bilious vomiting which can be there. There can be peptic ulcers. There can be peptic ulcers at anastomotic site. Why? Because now all the acid from the stomach is directly coming into the jejunum, right? Or there is no pylorus, so entire acid load is coming into the duodenum. So, and it is not getting neutralized. So these are conditions where there can be ulcers which can develop at the anastomotic site as well. So there can be peptic ulcers at anastomotic sites. Another complication is post-vigotomy diarrhea. Post-vigotomy diarrhea can be there. Now, this post-vigotomy diarrhea is usually an osmotic diarrhea which can be seen in patients. It is an osmotic diarrhea which can be seen, and it does not respond to octreotide. Okay, does not respond to octreotide. Okay. Another complication of vigotomy can be gallstone formation. Gallstone formation, I've already told you. There can be gallstone formation which can occur, and this gallstone formation occurs if we are doing a truncal vigotomy and the motor branch to the gallbladder is being cut. Now, another complication is impaired gastric emptying. There is impaired gastric emptying. And this impaired gastric emptying can be seen following vigotomy. It can be seen following vigotomy. And it has been noticed, and this is written in Sebastian also, that after vigotomy, there is loss of receptive relaxation in the stomach after meals. Right, so there's loss of receptive relaxation in the stomach after meals, and this can give rise to impaired gastric emptying, which can be seen. Now, this impaired gastric emptying can also be seen after Whipple surgery. If you go through the malignant pancreas module, after Whipple surgery also this impaired gastric emptying can be seen. And in fact, after Whipple surgery, this impaired or delayed gastric emptying is the most common complication after Whipple's surgery. Now, two very, very important complications. That's why I've left them right till the end. Before I tell you about those two, one which I've already told you about are internal hernias, are Stemmers and Peterson's. So those two I've already told you, internal hernias. Now the last two have been asked most frequently in the exam. These are nutritional complications. You can have nutritional complications following gastric reconstructions or gastric resection. And these nutritional complications, the most common is iron deficiency anemia. The most common is iron deficiency anemia. You can also get vitamin B12 deficiency, because you know that when you're cutting the stomach, there can be intrinsic factor problems and vitamin B12 absorption cannot occur. So vitamin B12 deficiency. And there can be calcium deficiency as well, calcium deficiency. So these are the nutritional complications which can occur after gastric resections. And you know that when we do bariatric surgery is weight loss surgery. There's a separate module on that which I've covered. And whenever we are doing bariatric surgery or we are cutting the stomach, these same nutritional complications can be seen there as well. And just last year in 2 exams, questions were asked from these nutritional complications. One question was that a patient undergoes a gastric resection and a few months later the patient is coming with anemia and the Peripheral smear shows microcytic hypochromic picture. Microcytic hypochromic picture is seen. What is the diagnosis? It will be iron deficiency anemia. It is going to be iron deficiency anemia. In the FMG exam, they had asked that a patient undergoes bariatric surgery and the patient is anemic. Patient has anemia, but it is megaloblastic picture. There is megaloblastic picture and neurological symptoms are also present. Neurological symptoms are also seen. So there the answer was vitamin B12. Okay. So such clinical stems can also be asked. This I've also covered in bariatric surgery. So you should definitely know about these nutritional complications. The final complication is dumping syndrome, and this is also very important from the MCQ point of view, and this comes as a standalone short note also in college exams. So dumping syndrome is of two types. You can either have early dumping or you can have late dumping. So first let me explain to you what dumping is and how does it develop, and then I'm going to write down the differences between the two. So dumping syndrome. Now, we had a patient who has undergone a Billroth 1 reconstruction. We know what a Billroth 1 reconstruction is, where this is the stomach and this is my duodenum. I've done a gastroduodenal anastomosis, an end-to-end gastroduodenal anastomosis has been done, and there is no pyloric sphincter now. The pylorus has been cut, so whatever food will come into the stomach will quickly go into the duodenum, Okay. So what is happening now? That this patient underwent a Billroth 1 reconstruction, and a few months after that, when he had recovered, he went out with his friends for a party. Okay. Now he hadn't had outside food for a long time, but now his friends said that, why don't you have something? Why don't you have something nice to eat? So he decided to have some sweets. So he had a chocolate brownie and he took a Coke as well. So he consumed X amount of sugar which was present in that brownie and that Coke. Okay. So when he took this X amount of sugar, this sugar rapidly came into the duodenum. Because there's no pyloric sphincter now. Now in physiology, Dr. Krishna Kumar has already told you the laws of fluid movement. When you have a hyperosmolar fluid, when you have hyperosmolar contents, they are going to attract fluid, right? So fluid rapidly moves into the duodenum to balance out this hyperosmolar solution. Fluid rapidly moves into the duodenum, and when fluid rapidly moves into the duodenum, suddenly there'll be distension, there'll be bloating, and the patient will feel nauseous, right? So those are the features of early dumping, where there's bloating, distension, and the patient feels nauseous. Now, the second thing which happens is that when the patient has consumed X amount of sugar, the body, has GLUT receptors. There are GLUT receptors everywhere. And they sense that, okay, this patient has had X amount of sugar. So, in response to this X amount of sugar, Y amount of insulin is already released to metabolize this sugar. Okay? But what has happened is that all this fluid which has come into the bowel, all the fluid which has come into the bowel, there has been a flood inside the bowel. And when there is a flood, what happens? Fluid moves quickly or it moves slowly. Correct. It will move quickly. So all this hyperosmolar content is going to move quickly through the bowel. And when it moves quickly through the bowel, the entire X is not absorbed. Entire sugar is not absorbed. So only part of the sugar is absorbed. Part of X is absorbed because of rapid transit. Why? Because of rapid transit. Now, when only part of the sugar is absorbed, but entire Y insulin has been released. So after some time, there'll be excessive insulin. And what will excessive insulin do? It will cause rebound hypoglycemia. And that rebound hypoglycemia is the cause of late dumping. Okay, so this is how early and late dumping develops. Before I tell you the differences, just one final point which I want you to know. So what if this patient, after 20-30 minutes, he decides to have another brownie? So if he has another brownie, what will happen to the hypoglycemia because of late dumping? It will improve. So consumption of more food will improve late dumping, but it is going to worsen early dumping. Okay, so that is another point which I wanted you to know. So let me now write down the differences between early and late dumping. So this is early and this is late dumping. Early dumping occurs because of rapid influx of fluid. Due to hyperosmolar contents in the bowel. Okay, so fluid will rapidly rush in and that will give rise to bloating, distension. Late dumping occurs because of rebound hypoglycemia, which is seen due to excessive insulin release. Okay. Now, early dumping, what are the clinical features? The clinical features would be bloating, nausea and vomiting, pain. And when will these symptoms start? These symptoms are going to start 10 to 20 minutes after meals. Will start 10 to 20 minutes as soon as the patient consumes meal. Within 10 to 20 minutes of that, the patient will start having symptoms. What will be the features of late dumping? There'll be the features of hypoglycemia. So there'll be headache, there'll be sweating, tachycardia, palpitations, nausea and vomiting. These will be the features of late dumping. Okay, and these features will start 30 to 40 minutes after meals. I've already told you that early dumping worsens with more food, whereas late dumping improves with more food. So that is improves with more food. So these are the differences between early and late dumping which you should know about. Now, how do we manage dumping syndrome, right? So management of dumping syndrome should be prevented and and what are the dietary changes which we tell to the patient? What are the dietary restrictions or the changes which we advise to the patient? Number one, patient should take small frequent meals. So they should take small frequent meals. They should avoid liquids with meals, right? Avoid liquids with meals, otherwise that will lead to rapid transit and faster gastric emptying. They should avoid sugar-rich meals. Which we've already discussed. That is going to worsen dumping. Avoid sugar-rich fluids, right? So Cokes and lemon water with a lot of sugar in it, milk with a lot of sugar in it, those things should be avoided. So avoid sugar-rich fluids. They should take a high-protein diet. A high-protein diet should be taken by these patients. So these are the dietary changes which one should be careful of in patients who've undergone gastric resections. Okay, these are the things which we tell to the patient. Now, if the patient has started developing dumping syndrome, octreotide can be used. Octreotide is useful in treating dumping syndrome. Now, if octreotide is also not useful, then we can convert the surgery to The last ditch attempt is to convert to Roux-en-Y. It has been seen that patients with Roux-en-Y gastrojejunostomy, the incidence of dumping is less than in Billroth 1 and Polya, right? So we can convert to a Roux-en-Y. That is the last ditch effort if the patient is not responding to the changes. So that was regarding dumping syndrome. And that brings me to the end of this module where I've spoken about these gastric reconstructions and the complications. The complications of these surgeries are equally important, namely dumping and the nutritional complications. Now, as is the case for all modules, I've been telling you about the important topics for final year students. So for final year students, what are the topics which are important here? So short note on dumping syndrome. Very important. Idiopathic hypertrophic pyloric stenosis. Short note. Every year in the exam, a short note is asked from idiopathic hypertrophic pyloric stenosis. So those are the two topics from which you should prepare short notes for your college exams. Sometimes there can be a long question on complications of vagotomy and gastric reconstructions. So complications of vagotomy and recon. This can be sometimes a long question which can be asked. Now let's just do some MCQs before we end this module. So which of the following statements is not true regarding idiopathic hypertrophic pyloric stenosis? Presents with non-bilious projectile vomiting around 3rd to 4th week of life. This is true. Ultrasound findings of pyloric channel more than 4 mm thickness and length more than 16 millimeters is diagnostic. This is also true. Metabolic abnormality is hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. This is true. And feeding can be started within 4 to 6 hours of an uneventful Ramsted's pyloromyotomy. This is also true. So sometimes the questions which I'm showing, you can get all true and all false as well. Which gastric ulcers respond to acid reducing surgery? This we've discussed is type 2 and type 3 gastric ulcers. A patient underwent total gastrectomy few months ago. What is the most common metabolic complication expected? We've just discussed this. This is iron deficiency anemia. A 26-year-old male was brought to the emergency department with abdominal pain and obstipation for 3 days. He gives a history of bull gore injury to the abdomen, right? A bull hit his abdomen. X-ray shown below. And what is there in the X-ray? We've discussed this so many times. This is gas under diaphragm. And gas under diaphragm, we know, is a sign of hollow viscous injury. When there is hollow viscous injury, we have to carry out laparotomy emergency. Surgery has to be done in these patients. So 45-year-old male with NSAID consumption presents to the emergency with severe abdominal pain. He has tachycardia, hypotension and rebound tenderness. Rebound tenderness, we know, are features of peritonitis. X-ray also shows gas under diaphragm. There is gas under diaphragm. So hollow viscous perforation, what do? Immediate laparotomy. You give fluids and you rush the patient to the theater. Regarding complications of vagotomy and gastric reconstructions, iron deficiency is the most common nutritional deficiency. This is true. Early dumping occurs because of rebound hypoglycemia. This is false. This is for late. Early dumping worsens with consumption of more food. This is true. Small frequent meals plus avoiding sugar-rich fluids reduces the incidence of dumping. True. Duodenal blowout occurs on day 4. And Stemmer's is hernia under the rule limb. This is false. This is the description of Peterson's hernia. So that brings me to the end of this very interesting module. In the next module, we'll talk about gastric cancer and gastric cancer management. Thank you.